Well, first of all, I'd like to start off by thanking Kent for sponsoring not only the Wound Week 2022 conference, but certainly providing us the opportunity to have some lunch and talk about near-infrared spectroscopy here this afternoon. I'd also like to thank my partner in crime up here, Dr. Tom Serena. Some people call it the Serena Niezgoda Show. I like to call it the Niezgoda Serena Show. Or the Dog and Pony Show. You can use any one of those. Yeah, anything works. Anything works. So again, welcome to Wound Week. We're getting near the end of this, and I can't be happier. I think things have gone very, very well, and I just can't tell you how pleased I am to be back in person. You know, shaking hands, looking in your eyes. This virtual Zoom stuff. If I don't have to do another Zoom meeting in my life, I'll be happy. You know. All right, Tom, so let's kick it off here. The technology, sort of explained it before, we're looking at near-infrared technology, and essentially what we're doing is we're taking the camera, taking a light, pushing into the tissues, and capturing that light reflectance, and looking at differences of where that light is absorbed, okay? And as we suggested to you earlier this morning, near-infrared technology is looking at a small spectrum of the entire wavelength of light between 700 and 1100 nanometers. It's been around for a long time, as I told you. When we first started these devices, I can remember playing with near-infrared spectroscopy and also hyperspectral. You probably remember those cameras.
I remember those cameras, yeah.
You had to actually wheel them around on a cart, and they were huge devices. Now the snapshot device is actually handheld. It's very small. Tom can't lift it by himself, but it is getting smaller, and
it's handy.
It's handy. So here's the look at the entire light spectrum there, and you can see that little carve out for the near infrared between 700 and 1100. And what we're doing is we're taking the camera, we're imaging the tissue, and we're looking at the absorption of unbound hemoglobin with oxygenated hemoglobin. There's a slight difference in the light absorption of those molecules, and we then capture that light back in the camera and run it through some very sophisticated algorithms, and then we get some data. And again, this is not hyperspectral. There are some hyperspectral devices out there, but they're different than this to a degree. This is the entire electromagnetic light spectrum. You can see microwave on one end, X-ray on the other. And we're looking at that near-infrared section of the electromagnetic spectrum, not hyperspectral. When you take a hyperspectral image, you're imaging over and over at all segments of the electromagnetic spectrum. Here again, we're taking a small segment, and this is very different than an RGB. We talked about RGB images earlier today, and that's what we actually see in a digital camera, the RGB image. So Tom, I suggest it's like the tip of the iceberg, and why don't you tell us a little bit about your experience in your clinic and why you gravitated to this based on the tip of the iceberg?
Well, so I think one of the real impetus to work with this group at Kent and the snapshot camera was really the fact that I don't like TCOMs. So when you mentioned that in your lecture earlier. A transcutaneous oxygen measurement, we were doing it routinely before hyperbaric and even in the chamber. It takes about an hour. I would propose today, I'm not sure that you even get approval for a TCOM today because the inter-rater reliability. In other words, if I do one and then my tech does one and someone else does one, the results can vary widely. And we saw that in a clinical trial. We did a critical limb ischemia trial, and what we found, I thought the machine was broken. But it wasn't. It was, and we had to do TCOMs every week, and they just went all over the place. So when we first learned about near-infrared spectroscopy, we naturally gravitated to it. And the first question, I think we're going to talk about this in a bit, but the first question was, does it correlate with TCOM? In a little bit, we'll show you it correlates very well. So we can take that body of literature and apply it to near-infrared. So we're using it to look at oxygenation, and I think you should look at perfusion, which is blood flow, and oxygenation. They're similar, but they are not equivalent. So we look at both oxygenation and perfusion, and we'll show you some examples where you're imaging that really makes a difference.
So we're going to spend some time talking about the interpretation. First of all, what do these images do for us clinically, and how do you interpret them? But as I suggested to you earlier this morning, I really feel that, up to just recently, all we had was this digital image, this RGB image, this digital photograph. And, obviously you capture one every week when the patient come in. And you can look at comparisons, but it's just such a small snapshot, if you will, of what's actually going on in this patient. Now, not only can we look at that, but we can actually look beneath the surface. We can judge what's happening as far as therapeutic interventions. So I think, like I said earlier, this is a game changer for us. So let's talk a little bit about the science. You want to walk us through this?
Sure. So hemoglobin loves red light, basically. And so we've been talking a lot about this morning, Alicia talked about electromagnetic spectrum. I feel like I've gone back to physics where we talk so much about it, but it's important. So hemoglobin loves light in that spectrum, so it absorbs it. But if you think about it, it'll absorb at different wavelengths, when you're looking at it, whether it has oxygen on it or not. So we can differentiate between hemoglobin and hemoglobin with oxygen, hemoglobin without oxygen, and that absorption. That would usually see in bullet 3. It passes through the skin, and so like the iceberg example, we're seeing underneath the skin. We're looking at oxygenation. And then you get an image, which is one of the beauties of the 5 wavelengths that it looks at, is that you also get an image. You can see it looks like a foot, right? So, some of the early versions of hyperspectral and others, it looked like snow. And so this is also very nice technology that allows us to actually image in a way that we can subsequently interpret it right on the spot, point of care. And that's really important.
Right. Perfect. So here's a video. I don't know that it's going to run. Maybe you guys can click on the video. But again, I referenced the free radical in the audience yesterday. My son Jonathan, who's aspiring to be a physician, and hopefully he'll join us. I don't know if that's going to play. Is it playing? No. Anyhow, John's done a lot of work with us in this technology, and it's great to have him working side by side. And I really enjoy having you here as well, young man. And John has a couple posters on this technology. So again, I would suggest that you go out and kind of take a look at those before the conference ends. Essentially what you do is you take the camera, you can see the red light there. Now that is actually just a reference light. There's 2 electrodes or 2 light lasers that you bring together, and that gives you an idea of whether you're too far away, too close. So you bring those laser points together, and that's when you take your snapshot. So it's pretty easy. Again, it's not all that large. It's very easy to handle, and you can. Oh, here we go. So you can see the flash. So you're really using the camera in a similar way that you would be using your digital photography. You then bring the display up. And here's Jonathan showing us how you get the image. You can pick different types of image, and we'll go into that a little bit. But by touching the screen, you'll actually get the saturation values here. Well done, John. All right, so these are what are produced. You saw these earlier. Again, we get a pre and post. We use pre and post images a lot. You can do these just once a visit, that sort of thing. You don't need to do them every time but we have found that it's really helpful to sort of help us guide some of our therapy. And this is just one example. We'll give more of them pre and post hyperbaric. What it's always the same, right? You take a picture, doesn't matter. You always get the same cut, right?
Yeah.
There are things that influence.
So there is, like all imaging technologies, there is sort of a learning curve with this, and I think what I find in the clinics is we introduce it in the clinic, and the first question they get is, well, how do I interpret the image? And it's and they start pressing for all the percentages all over the place, and it's not. it's not like that. That's really not the approach. It's an image, and it's intuitive, and you used to looking at the different colors, and when you look at the colors, you see the bluish areas, and you've taken the image correctly, then you know that you've got decreased oxygen supply. And there's a lot of reasons why you can have that. There's listed here. It could just be local problems with local perfusion, but it could also be systemic issues, anemia, hypoxemia, decreased cardiac output as well. And then high oxygen saturation we see in post HBO is the most common place we see it, but also after revascularization, and there can also be other reasons why you might see a high oxygen saturation.
Dr. Anderson gave us an example yesterday of how he's using this camera to sort of look at the state of healing and has that tissue matured. I think it's a very interesting finding. But again, you can use small variations in this tissue. So as Tom was saying, it's not an all or nothing. It's not, okay, I've got 90% perfect, because you are going to get other data from that image that can help you to focus and direct your therapy. So what are some of the clinical applications? I think certainly I am not a surgeon, so I don't do, that sort of work to a great degree other than what's out, what's in the clinic. But I think there's huge value here, and, you can carry this technology home with you, talk to your surgical colleagues about it. We're finding that after revascularization, tissue transfer, breast reconstruction work are all areas that I think we're going to start to see more adoption and use of this technology.
Yeah, I tell you, someone asked me a question about hyperbaric after the last lecture, and how are we using it? And you reminded me that by the flaps and grafts, and there's no easier way to document and to demonstrate that a flap or a graft is not doing very well as you're assessing for hyperbaric than to take a snapshot image. And it's intuitive, and we keep those in the chart so that if you're audited or whatever, then you can subsequently say, well, look, do you see blue, Mr. Medicare? And because that is a failing flap, and it's a great way to do that documentation.
Perfect. So in the wound care clinic, obviously that's where I live, and I've got a great deal of experience using it across the spectrum. Again, I don't use it I certainly use it this way, but I think there's more value in using it in other applications than just taking an image each visit. I use it to do a lot of comparative and get data to do comparative analysis of, am I making a difference? Can we somehow help this patient either prospectively or in a negative fashion? Just say, listen, we're not helping. But you can sort of see what's listed here as some of the experiences that we have, and we're going to share some of that with you. So let's talk about utilizing it. And we'll start to get in some of the interpretation of the images, if you will. So here's endovascular intervention. I showed these earlier. Clearly, you take the patient to the lab and you open up that anterior tibial artery and you look at them out of the angio suite, and you can't really see much difference when all you're doing is looking at the foot. However, you pull your snapshot out, you can say, my goodness, we made a difference in this patient. That's very favorable and can help us tell the patient, listen, not only did we fix that artery, but look at your foot. We're optimistic about salvage here.
Patients like the pictures.
Yeah, absolutely. And we're starting to put this stuff, you're seeing more and more literature in this area. I suggested, you take a look at the posters. Those posters hopefully will turn into publications, and you're starting to see the literature support what we're doing here. So I wanted to walk through this case. This is a patient that came to us and obviously had a bad-looking toe. And he was seen by our podiatry friends, and they took that toe out. And this is bad. Most of you sitting there saying, "Well, you need the camera for," and he's going, "Oh, that's not good." And yes, that is true. But the question is, are we making a difference from what we're doing? So here you see, again, the RGB image and the CAN image telling us that what we're seeing on the RGB, on the digital image, on the physical exam is in fact true. And we underwent some endovascular intervention, opened up the SFA, the popliteal artery, and tibial perineal trunk was lasered, PTA'd. um, improving distal flow. And again, following that intervention, we image it, we can suggest to the patient, hey, listen, we've got really decent response to the intervention. The tissue changes suggest that you're going to do well and go on and heal. And in fact, the patient did go on and heal.
Yeah, and it's a nice example to show not just the patient, but the vascular surgeon as well.
What are your observations pre and post some of these things like debridement?
Oh, I think you take images, and I'm a surgeon. I know what's in that wound, right? But sometimes we take an image and you're surprised by what you see, and you see an area that's poorly perfused, and you don't suspect it. Oftentimes, I suspect that there might be an infection, and so we'll take an image and then realize, well, it's not infection. It is an area that's poorly perfused, and you debride off that area, and obviously get down to tissue that is well perfused. So I think pre and post debridement is a great idea. The other thing I think is I'm not afraid to take a lot. I mean, I take a bunch of pictures in a day. It's not, you take as many images as you need. We do see across that with novice users, they tend to take one image and then they send me one image. I'm like, well, take more images and we'll put all these together as a picture of what's going on in that patient.
So what I want to show you in the next couple of slides is that there's different ways of debriding. You can take I'm not a big scalpel debrider kind of guy. I know Mario loves his scalpel, but I'm a curette guy. I'm really into the curette, and I think I can do a better job with a curette. But what's interesting about debridement is, you scrape all that grunge off the wound, and you look at after the debridement and say, hey, I did a pretty decent job. Unless you're in Serena's clinic, then you go, wow, did you really debride that wound? But what I'm really showing you here is that we have some tools out there that have additional effects, if you will, not just debridement. Ultrasound is a good example of that. With the acoustic streaming and the cavitation effects, you're actually taking that ultrasound and affecting the tissues. Do you get a response to that? With the naked eye, you can't tell. With Snapshot, you can. So here's a picture, again, pre-debridement and post-debridement. This was from my clinic, not Tom's. Nice job there.
It is a good job.
Yeah, really. And again, this was done with ultrasound. But again, can we complement what we're doing on a clinical basis by adding Snapshot? Well, look at that. Not only do we have a nice increase in perfusion, but you're seeing that increased oxygenation following debridement, again, suggesting that we're getting a better benefit than just scraping the grunge off.
And certainly if you're thinking of doing one of the grafts that we've heard about this morning or something, you want to make sure that you have a well-perfused bed, because the graft can't work if you don't have a good perfused bed, wound bed. And I mean, that goes to Bill's talk earlier. We were talking about people not following sort of the recommendations for using these rather expensive products and good wound bed preparation, proving that you have good wound bed preparation. It's important.
Now you see the circles with the numbers. You probably can't see those numbers, but again, you touch the screen and you get a value. Why is this important? I would encourage all of you that are not active in research to become active. It takes your clinical practice to another level. This is the sort of data that you can start collecting. There's all sorts of areas that we can explore with this technology. And I'll give you one example. I haven't looked at this, but I think it's important that you could look at it. We always talk about, in fact, in the review course, we talked about you don't debride dry calcaneal S scars, right? And there's a reason for that. But I think judging whether to debride or not is something that we could explore with this camera. And also not only when to debride, when not to debride, but how many debridements to do. So I think there's value here. We need more data. But again, I would encourage you to look at this from a research opportunity standpoint. Matt gave a great talk on shockwave therapy. I'm really jazzed about this therapy. I think it's going to, again, be something significant to bring to our patient. You might recognize the free electron there in that image. So Jonathan, again, is my right-hand man in clinic. I talked a little bit about this patient earlier today. This is really striking. Raynaud's, we don't have a lot to offer these patients. They are in terrible pain. And what do? You may put a little nitro paste on them, calcium channel blocker. I mean, you try all sorts of things. They don't do well. This patient came in, and I realized that Shockwave had great ability to decrease inflammation, increase blood flow. So I thought, why not? Let's just try it. This is the first case that I did on Raynaud's disease with shockwave. But again, the striking point here is if you look pre and post, you're not seeing much difference. But again, when you add near-infrared spectroscopy to it, holy moly, she's gotten an improvement. She's gotten a response to the therapy. Interestingly, she called me later that afternoon and said, Doc, I don't know what that funny thing that made noise was, but oh my goodness, my pain is gone. So we brought her in the next day, treat her again. She resolved that episode of her Raynaud's flare, which is really cool.
That's great. Yeah, there's not much to do for those folks.
And again, you see with the touchscreen effect, you can actually quantify the increase and change in the S. So Tom, tell me a little about this. I mean, you look at that, really, do you think that those subtle changes, we went from an 82 to a 91, how would you interpret this, and how would
that's a good question. I mean, so you're looking at that and saying, honestly, I probably wouldn't have touched the screen at this point because I've seen what I want to see. The number, maybe it's confirmatory, maybe makes me feel a little bit better, but I don't need it. And the way I run through clinic like a crazy person all the time, I would probably have stopped after this image and not even touched the screen for the percentage. It doesn't change. It's only good if it changes what I do. So I think I would encourage, as you're getting experience with this, interpret the image before you get to your percentage, because it's far more important to me to see what it shows visually than to actually have the number. Now, sometimes you want that number, right? And you want to chart it. But for the most part, I think it's sort of backwards to start with a number and then, now I'm going to look at the image. You look at the image, interpret the image first, and then you can add the number on later. And that's one of the mistakes I see people making early on in their use is it's blue. This is red. Okay, this is easy. So I know you've done a good job with the shockwave.
We haven't talked about that, but blue is
it's intuitive. So.
I showed this case earlier, Art Assist. Again, if you look at the changes in the tissue, say, yeah, that is good. Why is that patient responding well? Well, you add in near-infrared spectroscopy, you see that oxygen saturation has increased. Again, suggesting what we're doing makes sense. And you can certainly track this prospectively just looking at the wound and knowing that the patient's improving. But it's really comforting to tell that patient early on, I'll show you some other examples of that in fact, what we've decided to do for you is going to make a difference.
Yep.
And there went on to healing. We have a poster outside that talks about transdermal oxygen. This is a device called OxyBand. Essentially is an oxygen reservoir that is impermeable to the external environment. So the oxygen is only able to diffuse into the wound base through a semi-permeable membrane. So you put the membrane down onto the wound and you get a diffusion of oxygen for about 3 to 5 days. And so again, like a hyperbaric chamber, patient goes in, comes out, and you think, well, am I helping or not? Am I making a difference? Same thing here. This is a black box. Does OxyBand really make a difference in these patients? And so we looked at it with near-infrared spectroscopy. This is a patient. She had a Charcot foot disease, and I put OxyBand on. 3 days later, I saw that she had a nice increase in tissue saturation. And here you see an example of this patient. And, the question is, can I throw on one of the cellular tissue-based products that Dr. Tettelbach talked about, is the patient? Well, you know what? Based on that imagery, I saw the patient was responding. I felt a lot more comfortable putting the graft on. And so we ended up putting the graft on, and lo and behold, she did great. And again, it just provides a little extra degree of comfort to know what you're doing is going to have a positive outcome.
Yeah. Hey, it's funny because we've lived so long, well, I have anyway, but without diagnostics. And I do find sometimes people are a little resistant to add diagnostics to their wound care. But if you go to any other medical specialty anywhere else, they take out their EKG and their echo machine, and they do exam, and then they do diagnostics. And I think it's a funny field, wound care. I don't see people embracing diagnostics like other medical fields. And once you start using diagnostics in your practice and really seeing what's going on, I do anyway. I become very dependent on them. I'm going to use them to help me extend my ability to do physical examination.
This is my patient. I'm going to ask Tom for his opinion on interpretation, but this is a gentleman that underwent Mohs surgery for a squamous cell of the scalp, and they grafted it immediately after, and obviously the graft did not do so well. And so we used the transdermal oxygen as part of his regimen. He also got some hyperbaric treatment along with it. But Tom, so you don't know this case real well. Tell me what you look.
I don't know this case at all, but so you look at the pre and you see dead tissue, the black. It's clearly not perfused at all. And that's probably the dead. That's certainly the dead graft. But you look in the center. It's not. That is not getting a lot of perfusion. It needs. What does it need? It's a low oxygen saturation. It needs oxygen. So you add the transdermal oxygen. You see still some dead tissue there that'll have to come out at some point. But now you see the nice red color. And again, at this point, I don't. I might touch it just because I like getting that percentage, but I don't need to. At this point, I can say, this therapy is working. And if it didn't, if it came back the same, you'd say, I need to do something different.
I'm going to, again, use Chuck here talking about the inflammatory hue around these wounds. If you look at the panel to your upper right, you can see that not only have we increased the red colors in the center of the wound, we're seeing more of a robust yellow rim around that tissue. Suggesting that we're changing the tissue dynamics. We're seeing that inflammatory, that increased perfusion response. And I think, not only are the absolute values of what you see in the wound important, but what's going on around that wound and the outside tissues as well.
Yeah, there's no doubt about it. I mean, that you can look at that and say that wound looks, that skin looks a lot better.
So we followed him forward, and here's a nice example of, as we move forward, the patient, does a nice job of moving forward from an RGB, a radial digital image, reflecting what we're seeing here on the near-infrared images as well. Nice. To complete healing, yeah. So hyperbaric, obviously, we are fans of hyperbaric and have been doing it for a long time. Tom talked about TCOMs, and when I started doing this, that's all we had. And we would measure, pre-hyperbaric, and we'd say, yeah, your numbers are really crummy. We're going to put you in the chamber, and they're going to improve. But really, rarely did we test TCOMs in the chamber because it was so cumbersome. So you really couldn't assess, as quickly as we do now with Snapshot, how they're responding to the hyperbaric therapy. These chambers here are chambers at AZH in Milwaukee. They're really, really cool. I love them. These are Techna chambers. If anybody is shopping for monoplace chambers, give me a call. I'll push you towards Techna. These are the best best monoplace chambers on the market right now, and they're less expensive than some of the others. So I showed you this very briefly. Again, this is a case of frostbite. We see a fair number of cases of frostbite in Milwaukee.
I would bet you do.
Yeah. And this patient came in with these dusky fingertips. Now again, it doesn't take a wizard to look at this and go, yeah, you've got some tissue issues there and damage. And we treated with image with the Kent camera. And what we saw on the RGB image is reflected here on the near-infrared image. Post-hyperbaric, again, you look at the tissue and say, so the patient's like, hey, doc, this doesn't look any worse, any better to me. Again, you image and you show this, you can actually show these images to the patient, say, hey, this is going to work. We have a good feeling that you're going to respond well. There's a paper out on negative and positive predictability. I'll share some of that data. If you were actually to measure the tissue oxygen saturation, you can see a profound jump. And I think as we start to accumulate more data, we're going to have the ability to do sort of what we did with TCAM, have actually cut off and say, listen, you're under 30, there's no hope, or you're augmenting with hyperbaric, we have a shot. I think you see the same thing with these. Again, pre-hyperbaric, the near-infrared camera suggests that that's what we're seeing. Post, maybe a little bit of improvement, but yeah, that makes you feel a lot more comfortable. This is a patient that I didn't walk you through the entire case, but He was an industrial kind of guy who worked in a sheet metal shop, and one of the devices, I don't remember exactly what it was, came down his finger, crushed it, and really caused him some problem. There's exposed bone there. Just trust me, there is. You could probe it and just take a Q-tip. And I would say 5 years ago, I would have sent this guy to my colleague hand surgeon for a distal. He didn't want that, and I imaged him early on, and I looked at the changes, and I'm like, we got a shot here, and we pushed forward. And he did completely heal with some, obviously some aggressive wound care and hyperbaric. Did very, very nicely. So, Tom, I told you that we've got a poster out there that Jonathan and I have looked at positive and negative predictability. And I think that's really the direction we need to start going in wound care. Whereas if we can make decisions earlier in our treatment course, we can have a huge impact on the finances of the medical system.
Exactly.
Is the patient appropriate for certain cellular tissue-based products? Is the intervention working? Is it not working? Do they need an amputation earlier? What do you think?
No, I agree. That's the beauty of the advent of diagnostics in wound care. We can begin to develop objective criteria to add to our physical examination. People said to me, "Oh, when are you going to retire?" Well, I'm not retiring till the Wagner classification is dead. Because it's horrible. I mean, it's 40 years old. It is not. It has very low predictability, and yet we use a lot of our hyperbaric based on this incredibly inaccurate and unreliable staging system. Because if you don't, your patient's going to get a great big bill.
Yeah.
So we need to develop diagnostic tools that have predictability. And I think we're really excited about this. We have a clinical trial ongoing now where we're looking at this predictability and saying, okay, can I combine several of the diagnostics you've heard about today and develop an objective score that says this patient should have hyperbaric, this patient should have a CTP, and then if they do, then this is what we expect results-wise. And that we have to get there.
So this is early data, and I apologize I don't have, what Dr. Tettelbach showed you, 50,000 cases. This is just a small snapshot of what our clinical practice, but I really believe this is very thought-provoking, and I think it's going to lead us in the direction for some of this prospective prognosis, both on a positive predictability, looking at it and saying, listen, I'm sorry, there's really not much we can do. You really should get that amputation done early. Or, on the other hand, hey, listen, I think we got a shot here. Let's push forward. So I think it's important from a positive standpoint, but also from a negative standpoint. I think that this negative predictability is also where we can start to save money. I will tell you the vast majority of the clinics across the country, patient comes in for hyperbaric, and what is written on the order is 40 sessions. Okay? And that's really caused us problems from a standpoint of Medicare looking over our shoulder because they use this term overutilization. And you know what? In all honesty, I think there's a lot of that going on out there. We can have an image to find out, number one, is the patient responding to hyperbaric? And number two, what kind of response and can we help that patient or not? I think we can, not only hyperbaric, but other things.
It's not just should the patient have hyperbaric, as we mentioned, it's also how are they doing in hyperbaric? Or, when you have your cellular and tissue-based products, should I put another one on? Where am I? I mean, I think Bill's data was very good when we talked about, only 9% of the people actually use these products based on their intended use. Well, I think diagnostics might play a real important role in getting folks to use these products the way they should. You take an image, the image tells you what to do next. So you don't just sort of say, sounds like a good idea.
So I'm going to share with you, this poster's hanging outside, but I just want to share some of these cases here. You saw this guy before. This is our frostbite. And again, I apologize if you can't see those numbers real well, but if we take and we test for STO2, get the numbers and compare them, he's got an average change of 37%. He went on to complete healing. This is another patient that really, again, years past, she would have had an amputation. She was a patient that underwent a podiatric procedure and actually showered after the tourniquet, showered some plaque distally, and really that third toe there was essentially necrotic. And imaged her, looked at the changes, Not as striking as the one before, but she healed with an average change of 10%. And this, you saw this case again, this average change of 15. All those patients went on to heal. Vice versa, alternatively, this patient here came in with a big black toe, and I was not optimistic. We imaged, and in fact, after hyperbaric treatment, the change was very small, 8.5%. He went on to have an amputation. Here's another patient, and you look at, I should probably put the RGB images up here, but this is not that bad of an ulcer. It was a Wagner 3 ulcer. But the bottom line is that pre and post hyperbaric, really minimal response. In fact, he went on to a BK. Here's another patient, again, necrotic distal digits. And again, if you notice the change, this is hyperbaric, so we're really kicking this tissue. No change at all to a degree, 5%. He went on to have a TMA. So I think this data is really early, but Jonathan and I took a look at it, and I think there's some interesting findings here. These are just averages, so there's not much statistical analysis that is done here. But on average, those 3 cases had an average change of 20.9%. The negative outcomes had a change of about 5.7. So if you look at it in more detail, you can say, hey, maybe about 10% change predicts a positive outcome versus negative. So again, very preliminary. I'm not trying to hang my hat on it, but I think it's interesting.
I think by next year at this meeting, next wound week, we'll have these answers. Yeah. We'll know what these numbers, these percentage changes are.
So Tom suggested that you can use this for insurance issues, and boy, that really works. Here's a patient that came into us, and it's kind of interesting because when I used to work for the hospital system, I did the hyperbaric program there. He actually went to that program, and they turned him down and said, sorry, you don't qualify for hyperbaric. So he got on Google and found me and came in and said, Doc, I'd really like to pay for these treatments. And I'm like, why pay for them? I think we can get this covered. He's like, what? So I took the images here, and obviously this is what I sent to the insurance company. So I didn't take and trust the fact that, whoever's looking at this review would understand. So I put circles around the tissue, and it says tissue ischemia, incisional compromise. But more importantly, I actually imaged it with near-infrared spectroscopy, put them in the chamber. I said, this is the image. Came out of the chamber, and again, you look at that area right in the center there, that's the watershed area. That's where we're concerned about. That's what's compromising that incision. And in fact, he had a nice augmentation. Sent this off to the insurance company. Day later, they called me and said, Doctor needs to go ahead with your treatments. Well, guess what? Aurora found out about it and sucked him back in and started billing for him. But I think that this is very, very helpful as well. Tom, I'm going to let you talk about your experience here because you're the expert, man. You're published.
So I got into this really because I couldn't tolerate doing TCOMs anymore, and the results were highly variable. Our TCOM machine is only now used for research, and so we started off by saying, well, can we use the snapshot rather than the TCOM? The first thing we needed to do was correlate those. Can we correlate the TCOM machine results with the near infrared? And so we did a study, and I think about 25 patients, and we did TCOMs and we did snapshots. It was actually kind of a challenging study because remember, TCOM heats the skin. So when we first started doing, we heat the skin, and that makes it look like there's more. It gives it an impression that there's more perfusion. So after making a lot of mistakes, which is what clinical trials are all about, we were able to then do a study where we looked at and correlated, and they correlate very well. I mean, there's a formula to get from free oxygen to oxygen saturation, but they correlated very well. And I think this is what really got us excited and sort of led to the next phase in the research, which is now what is the predictability? What's the best way to use this device, not only just to make a point of care diagnostic, but to make a predictive diagnostic as well.
So this, again, I'm blowing Jonathan's horn here today, but this is some work Johnny did, and you can see the electrodes A and B, those TCOM electrodes, 69 and 52. And then what he did is he sampled around the electrode in multiple sites, and we got averages there. And you see the correlation, 69, 64. These are not statistically different in variation. So again, the values you get with your snapshot near-infrared spectroscopy correlates very, very well.
And just from a practical standpoint, you can't put, a TCOM probe in the wound. And lots of times what you want to know is what's the oxygenation in the wound, or that patient with that flap. It's really hard to know where to put that lead. So that's one of the first things we noticed the current study we're doing now is I can image anywhere I want, and I don't have to worry about bony prominences. I don't have to worry about putting it too close to the wound. And that's a huge advantage in the wound clinic.
Right, absolutely. So again, negative predictability, we talked about that. I think if you can make decisions in the patient's interest, even though that may be an amputation, if you do that earlier, you're going to get them back to their usual lifestyle quicker, return to work faster. If they're in the hospital, you may make decisions that get them out of the hospital faster. And those sort of decisions, I think, really have an ability to save us overall cost of care. Here's the RGB images of that patient I showed you earlier. But again, looking at that, you say, well, these go to, yeah, I could make that decision without. But you know what? The patient may not want that amputation right away. How many times have we take care of patients that we go, yeah, you really need to have that digitate? Oh, doc, no, I don't want to do it. See if you can salvage it. But this really helps. You take the snapshot, you show, we really can't help you. And I think it does make a difference. And again, this is my pre and post patient with frostbite that went on to have those digits amputated. So we do a lot of surveillance. I think that Tom has suggested that we can get that snapshot and really get some immediate feedback from what we're doing. You can use it prospectively over time, looking at every visit. And so I think that this bedside test is really complementary to the practice.
It is. It's easy. It's fast, and you can follow it longitudinally. If you look at most, a lot of imaging that's done, it's a longitudinal imaging. So we get nice information when you first take it, but sometimes it's even more valuable the information you get by taking serial images over time.
And this is how we sort of look at it again: 1 week summaries and outcome improvements. So it's very. So the advantages are certainly it decreases time of assessment compared to TCOMs. This thing, you can get an image in less than a minute. TCOM is a 45-minute, tie up a room, tie up a technician. There really is no disposable cost as opposed to the TCOM machine. It's certainly less invasive than anything else we have. And again, this in situ, this bedside analysis, I think is really important. There is an expert on reimbursement here in the room, Moira. Where are you? Moira's waving her hand, wearing the blue scrubs. If you have questions about that, I'm not going to spend, we're kind of getting near the end of time. If you have questions about that, please go to Moira. There are codes that are available that are being fairly well reimbursed. And again, as I suggested earlier, we're starting to develop our body of evidence. There's opportunity for all of you here. If you're looking at an area where you want to do some research, this is a great place to dig in because there's a lot of different opportunities here. So, Tom, with that, I'm going to thank you. Thank all of you. Thank the folks at Kent.